I wanted to talk to you about time management in the ER and moving a patient from the ER on through to the floor and how it kind of works, as well as your time management and your tasks. What is it that you're going to need to do with these particular patients? So the patient that I want to discuss today is a patient who fell. They didn't fall in the ER, but it is a fall in the ED that we are covering. So your patient is a 78-year-old female. She slipped on a rug and hit her head on the coffee table. She is positive for taking Coumadin. There was no known loss of consciousness. She doesn't know if she lost consciousness or not. She is currently altered in her mental status and has a hematoma to the left orbital. The EMS stated that she was sitting up on the floor upon their arrival, alert and oriented to person only. Her husband came along. He says that her baseline is usually alert and oriented times 4. So what is the first thing that we need to do with this patient who's just come in on a stretcher into the ER? The very first thing that we need to do is we need to get a set of vitals on this patient. So we have a temp of 98 degrees. That is okay. Heart rate 65, again, also okay. The blood pressure 100/72. Now, this is slightly low. There's a few things that I would do here. The first thing is that I look at the mean arterial pressure is 81. So it's between 60 and 100. So I'm not super alarmed right at this moment. I definitely want to keep an eye on that. The second thing that I would do is I would look. I mean, she is 78 years old. It is likely she's been to the hospital before, and I would see what are her trending blood pressures. Has she ever had a blood pressure in our chart system before? Are they usually low? Is this normal for her? And then I would ask the patient if she's got any signs and symptoms of a low blood pressure. Is she dizzy? Anything along those lines. Her respirations are 16. That's within normal limits. And her oxygen is 99%. She came in on 2 liters. Now, I would originally, if I can, if there isn't any sort of huge push, I would try to take her off of the oxygen and get a baseline oxygen, but that is not a priority for me at this time. The priority is that she hit her head. She has a hematoma in her left eye, and she's taking Coumadin, and that she's also altered. So I'm thinking about her brain right now, and that oxygen is probably, it could be totally fine without the 2 liters, but it's giving her an extra boost to oxygenate all of her tissues. I'm leaving it on for right now. The second thing I would do after getting vitals is I would start an IV and grab labs as quickly as possible. And the number one lab, the important thing that you want to look at here are your coags. So your PT, PTT, INR, those kinds of labs. You want to check and see how her bleeding levels are at. The third thing that is after you've gotten the vitals in the IV, while you're doing that, and you're likely going to be having help, so maybe even delegating off the vitals and delegating off IV labs, you want to call the CT scanner and have them clear the table, because we need to have this patient down as quickly as possible. Make sure that they're not having a brain bleed or anything along those lines. And while you're in there, you're going to be doing a quick assessment of facial symmetry, slurred speech, a quick hand grip to see if they're equal, anything along those lines. And you're going to be asking those questions. Do you know where you're at? Do you know why you came here? What is your name and birth date? Who's the president? Things like that. You're going to be wanting to shoot off a few questions at the patient to assess your own orientation status as well. But never let this impede or slow down how fast you get to the CT scanner. That is the number one priority in this situation. So we will be running down to CT to get a scan of the head and the maxillofacial bones, just to see if she has any sort of eye orbital fractures or anything along those lines. And if she is complaining, like if she is complaining of like elbow pain or anything like that, they may do x-rays as well, which are important, but they're not the number one vital thing, which is the CT. I would also get it after the CT, unless the CT is delayed for any reason, I would get an EKG on this patient, just to check to see how their heart is doing and if they're in any sort of strange rhythm that could have potentially caused them to fall. Sometimes if the patient's heart isn't working right, or even the low blood pressure could have been a cause of the fall. If there's some sort of issue related to that, that could have been a cause to the fall. So I would get an EKG, and then also check to see if they've ever been in something like AFib or whatever that might be, whatever rhythm they may have had in the past. So after the EKG, you're putting them on a monitor. I mean, they're never going to come off of that monitor really until everything comes back stable and normal and that patient is alert and oriented. So you will be doing an EKG as well as a monitor. This patient's going to be NPO, so nothing per oral, or however it's pronounced, or osphos, nothing to eat. So we will be doing, again, as soon as they come in, vital signs, IV labs are sending off those coags. We are going to get a CT scan of the head as quickly as possible, and EKG, cardiac monitor, and x-rays if there's any extra. Usually CT and your x-ray teams are working in the same vicinity, and so if you're at CT and you are able to go in for an x-ray real quick, then you can slide the patient in for that. So we would be waiting on the CT results, and then blood work, and we're going to come up with a plan based on those. So first of all, I pointed out here INR, because your INR is what we use to gauge our Coumadin. So this patient is taking Coumadin. We want to see what their INR is. Is it too high? Is it therapeutic? What do we have going on for the INR, for our coags in general, but specifically the INR? And then the CT comes back. This patient does, in fact, have a subdural bleed. So it's small. It's not causing any asymmetry at this time. Subdural bleed. And there are, in fact, some fractures. It's FX. There are some fractures of her left orbital eye. So orbital fractures. So our Coumadin comes back and it is elevated. Okay, that's dependent upon what the doctor originally wanted their Coumadin levels to be. What they're on Coumadin for can determine what we want their therapeutic levels to be, and then also what your laboratory values are. So I'm not going to give you a level, but I am going to state that it is high. So our plan is to stop the Coumadin and bring that Coumadin level down. We're going to admit this patient, and we are going to be monitoring for neurostatus. We want to make sure that this bleed up here doesn't get any worse than it already is. So our patient came in, they got vital signs right away, IV blood work, and then they were off to that CT scanner. We waited for results, got an EKG in there. The EKG was fine, and we found out that she does have a little brain bleed we need to worry about, and then facial fractures. So you are going to admit this patient to the neuro ICU. Let's say they went ahead and got a bed. You're going to call report. You, if in between the time that the patient has been scanned, because it was a brain bleed, it's less, you're not going to have as much one-on-one time as you would on a patient who is having an ischemic stroke, who has a blood clot up in their brain, because you'll be doing the neuro checks every 5 minutes and then every 15, and then you just keep going on with that. So for this patient, you want to make sure that as an ER nurse, you have put in as complete and full of a neuro assessment as you possibly can. So you'll call report, you'll give that neuro assessment, you'll let them know, hey, the plan is that we're going to be doing Q 1 hour neuro assessments, or whatever the doctor has ordered. And then we're going to try and bring down their Coumadin level. We're going to hold it for a little bit, and give them the level that the doctor would like them to be at. So once you receive this patient up in the neuro ICU, the first thing you're going to want to do is get vitals. And you will notice this on all of my patients. The first thing I do is get vitals. Unless that patient has an ABC issue that I need to be taking care of right this minute, or they may die, I'm getting vitals on every patient. Even if I've come in and I've had a patient who has been there for a few hours, I'm getting vitals on them. I always want a baseline of vital signs on my patients. The neuro ICU nurse is also going to do a neuro check despite whatever time that neuro check is due. And then they're going to probably schedule their future neuro checks out from there, and or take it from whatever the ED nurse has started the timeline on and continue from there. But there's still going to be their own personal neuro check immediately upon arrival of the room. Especially in the neuro ICU. I mean, neuro ICU nurses own those neuro checks. So I would then put in an assessment, checking the skin. This patient's going to be obviously a major fall risk. So you want to set up whatever systems you have in place, making sure the patient's close to the nurse's station, making sure that you have a bedside commode, or that you are able to get to them quickly, or however you want to set them up on a toileting schedule, whatever it is that you need to make sure that this patient is not out of bed without an assistant at all times, especially because their orientation status is just to person. So they're confused. They probably aren't going to remember that you don't want them to get out of bed, and they may not even remember where they're at. So these are all things that you need to keep in mind when you're assessing the patient. And then you also, so you've scheduled a plan for neurochecks. You want to also schedule for another INR draw to check to see if it's within the normal limits. And that's per facility. So however many hours, they may just have it be the next day, the next morning that draw is due. They may have it be due every so often per hours. So that's something that you'll want to schedule in. And when you're doing your assessment, I mean, I know you've already done your neuro check, so you've already asked all the pertinent questions. But if the husband is still at bedside, you want to make sure during your assessment that you explain to him, at least this is what I would do, explain to him why you're asking these questions. What are the things that you're concerned about? I'm checking their pupils, and I would say to the husband, I'm concerned that her pupils become fixed and they don't dilate, or I'm concerned that they become uneven. So explaining to the husband and keeping the husband in on the loop of everything that's going on generally tends to, in my experience, make them feel like they're important and a part of the plan, which they are important, but being a part of the plan is super helpful for them. And it also gives you, the nurse, another set of eyes on that patient. So if I'm telling him that if she all of a sudden becomes really confused about who she is, I want to know. I need you putting on that call light, because I might not be in the room right at that second, but I want to know what's going on with that patient. So just keeping that husband in the loop of what assessments you're doing and why you're doing them to help them out. I think that helps out with your time management, and also helps keep your eyes on that patient really well. So just to recap, we had a patient come in for a fall in the ER. They had an immediate set of vital signs and IV blood work, and we sent that patient straight to the CT scanner. They did have a subdural bleed. Now, it wasn't something that was super pressing. It wasn't causing any issues right then. We didn't need to do like a ventric to release any of the pressure. That might be something if the hemorrhage continues to grow, then they'll want to do that. If not, then they'll just monitor it. Hopefully it doesn't get any bigger. Hopefully it gets smaller, or stays the same. And then we waited for CT results. We did an extra x-ray. She fell on her left side. And then we admitted her to the neuro ICU, where they are going to be strict on those neuro checks and helping to bring that INR level back down to a normal level. And as far as the facial bones being broken, that depends on the doctor and the severity of it. So if it were to be something that needed surgery, they wouldn't be doing surgery right away anyway because of the Coumadin on board. So they would have to have that reversed before they would take her into surgery. But generally, it's something that will heal without surgery. So I hope that helped you guys with the fall patient in the ER and the neuro ICU.